I always like these catchy titles. They get lots of popular attendance at conferences. So surgeon beware, you're going to talk about peripheral neurologic conditions that might masquerade as radiculopathy. So let's get to the meat. So I have a couple theorems. I think this one is something I think about every day. Not all that radiates is radicular. And my second one is that numbness and nerve pain are nebulous. I think many of you have seen this. And so just when you think you figured out a pattern, the rules change a bit because patients have a hard time mapping where their nerve pain is and mapping where their numbness is. So, all right, so let's talk about those patterns. I think we've all had beaten into our brains the dermatologic patterns of C5, C6, C7, C8. These are fairly well described in multiple different publications. We all know the peripheral nerve distributions. We had to probably draw this on exams, and we regurgitate it frequently when we're pimped in neuroscience grand rounds and whatnot. So I'm not going to reiterate this. Typical peripheral nerve patterns are not necessarily always as boundaried as you think they should be. And we have these other patterns that sometimes cloud the picture, one of which is the sclerotomal pattern. And this is based on radiating pain patterns that stem from bony anatomy. And this has to do with embryology and the innervation of these different structures, much as the appendix radiates, irritates the diaphragm, radiates to the shoulder, which is innervated by the same segments as diaphragm. You can map out where the C5, 6, C4, 5, and whatnot facet joints can radiate in some patients. And then you have myofascial pain patterns, which are far less defined and less accepted among practitioners. But in this case, this is a picture of someone with a scalene trigger point or a taut muscle band that has a radiating pattern that sure looks a whole heck of a lot like a C6 radiculopathy. So we're going to do a few cases so that I can keep you awake. So this is a 34-year-old male with insidious onset left shoulder pain for a week. He went to the ED because it was such severe pain. No trauma, woke with symptoms a week ago, had an old motor vehicle collision with a whiplash 9 months ago, but a normal exam in the ER. His MRI showed some wear and tear, degenerative changes. He was diagnosed with a left cervical radiculopathy. Given a methylprednisolone burst and taper, and he was given instructions to follow up as an outpatient with his friendly neighborhood physiatrist. So 3 weeks later, he establishes care with the team. Pain was gone by that point, but we dug out that he'd had a really nasty case of stomach flu about 4 weeks ago, not long before the symptoms started. But when we saw him, he had new weakness. So now he has medial border winging of the scapula on the symptomatic side with weak shoulder external rotation and abduction, but 5 out of 5 otherwise. Sensory exam was normal, and he was tender in various muscles around the scapular supporters. We diagnosed him with a left brachial plexopathy involving the long thoracic and suprascapular nerves, consistent with Parsonage-Turner syndrome, based on electrodiagnostic studies, and started him in some physical therapy. So many of you have seen scapular winging, but I think a lot of people don't take a patient's shirt or gown off to look for it. And so it's important to stand behind them, disrobe the patient enough, and put them through some maneuvers where they actually have to move their shoulder. Just sitting in a chair, you may not see it. I usually do a forward flexion maneuver, a shoulder abduction maneuver, and sometimes a corner push-up are some things you can do to try and identify this. And I've seen profound scapular winging where you can just about get your head under the patient's scapula, but I've also seen subtle scapular winging in patients with a totally normal neurologic exam, just from muscular imbalances and poor scapular posture. As our PTs in the back nod, as everyone adjusts their posture. So let's talk about Parsonage-Turner syndrome. I like the name Parsonage-Turner syndrome. It's pretty clear when you say Parsonage-Turner syndrome what it is, but you may have heard it called brachial amyotrophy, neuralgic amyotrophy, or idiopathic brachial plexitis. So it's about an incidence of 2 in 100,000, a little more in males than females. And what's interesting is it has this classic presentation. 95% present with this insidious onset of fairly severe, like ER visit type pain. And then the pain tends to go away in about 2, sometimes 4 weeks, and then weakness comes in its wake. Only about 67% have a sensory deficit, and it's usually the axillary or the lateral antebrachial cutaneous. About half of patients, it's just confined to the shoulder girdle, and in 10% of patients, it's just one single nerve, and sometimes It's the phrenic nerve. So it's a sneaky little beast of a condition. 66% are unilateral, but 54% of those are right. And about 2 out of 3 have scapular winging, but you got to look for it. So sometimes you can find an antecedent trigger, some sort of infection, and there's quite a few listed there, various viral and bacterial infections, vaccinations, immunizations. But interestingly, pregnancy, surgery, trauma, vasculitis, and then there's a hereditary form as well. And probably the toughest case I saw was a patient who had a C5-6 discectomy fusion with a foraminotomy who then presented with Parsonage-Turner syndrome, and those are sneaky and really tough to distinguish. So why does this happen? We think that it probably occurs about the same pathophysiology as Guillain-Barré syndrome, where viral entities have an epitope or a projected protein on the viral surface that then is recognized, antibodies form, and unfortunately that creates this phenomenon known as molecular mimicry, where your antibodies then basically attack peripheral nerve components. So it's an autoimmune phenomenon. And what's interesting about Parsonage-Turner is it really likes motor nerves. It has a preference for the suprascapular and long thoracic branches, but I've seen it in musculocutaneous, you can see it in axillary, the dorsal scapular or spinal accessory, which are common for scapular winging, the phrenic nerve, and then occasionally you'll see it in the anterior interosseous nerve or the posterior interosseous. It doesn't tend to have sensory components, but when it does, sometimes it's the lateral antebrachial cutaneous, which is peculiar. So if you send somebody for an EMG and they just get, routine run-of-the-mill radic screen and rule out carpal tunnel, you'll probably miss it. You've got to actually look at those proximal motor nerves, and those nerve conduction studies are more challenging. They don't have great normative data, and they're not well taught in residency programs. And so if you think someone has got Parsonage-Turner syndrome, you've got to make certain to send to someone who has a fair amount of experience in electrodiagnostics. So how do you treat it? It's mostly supportive with physical therapy, strengthening, range of motion. We want to prevent adhesive capsulitis and contracture, preserve function. The literature says that about 36% have recovered fully by the end of year 1, 75% by the end of year 2, and 89% by the end of year 3. If they have distal muscle involvement below the elbow, they tend to have a poorer and longer recovery course. And a phrenic nerve recovery tends to be globally poor, and patients have typically lifelong hemidiaphragm paralysis. So how do nerves recover? This is maybe a little bit out of the scope of this, but I was asked to talk a little bit about, timeline of nerve recovery. And there are various patterns by which nerves can recover. The most ideal is axonal regeneration, where you actually have regrowth of axons from proximal to distal to the end organ, to the muscle. The idea there is over time, you actually get return of normal nerve conduction parameters. It's very slow, somewhere between 1.5 to 5 millimeters per day. I usually tell my patients it grows about as fast as their hair and their fingernails. It's faster proximally, and it tends to fizzle out and slow down as time continues, and often it's incomplete. We think that there's something about exoplasmic flow and getting nutrients to that nerve as it recovers, that eventually it fizzles out and you get failure of the axon to reach the end organ for longer distances. And this is partly due to shrinkage of the endoneurial tube, death of the cell body, and this leaves patients with persistent numbness and weakness, obviously. The less ideal pattern for recovery is collateral sprouting, which often is going on simultaneously with axonal regeneration. And collateral sprouting involves just sprouting of the terminal axons to reinnervate the end organ. The problem with this is that it's like plugging too many devices into an outlet. And so you get overtaxing of that motor unit as a whole, and it results in poor motor endurance and fatigability, even lifelong after they've recovered those segments. So here's a lovely depiction of collateral sprouting. Okay, so case 2, and this will be a pretty quick one, the numb hand. And the reason I want to talk about the numb hand, and I'm not going to belabor carpal tunnel syndrome, but I reached out to our esteemed anatomist, Dr. Tubbs, and asked him, hey, there was this landmark publication about 97 years ago that talks about variant anatomy for sensory innervation to the hand. So I wanted to share that with you, because I think most of us, if we examine a patient and they've got numbness on the radial aspect of their ring finger and not on the ulnar aspect, and it maps out, it looks very carpal tunnel-y, we use that as maybe a sign for potential carpal tunnel. But I just want to say 72% of us split our ring finger down the middle. At least we did back in 1918. Whereas 20% of median nerve distribution does not even go to the ring finger, and 4% split right down the long finger. So we probably shouldn't put too much weight in some of the maps that we've learned. And then for ulnar, there's quite a bit of variation as well, where 79% have the typical pattern that we saw on that slide moments ago, but then you have 14% that involves the entire ring finger, and actually 3% where their sensation is ulnar, going into that ulnar digital branch of the long finger. So that's about all I'm going to talk about with the hand. So case 3, the numb and weak thigh. So here we have a 62-year-old obese male who has insidious onset of subacute pain and paresthesias in the right anterolateral thigh with low back pain for 4 weeks and some mild knee buckling when descending stairs. Negative straight leg raise on exam, but he's weak with knee extension and hip flexion. He has no Achilles reflexes, but a diminished right patella reflex on the symptomatic side. Absent vibratory sensation at the great toes, and diminished sensation in the right anterolateral thigh and medial foreleg. And of course, his MRI looks like most 62-year-olds with a lot of multi-level facet changes, foraminal stenosis, worse at typical levels. So, we all see this, and it's easy to kind of go to, L4 radiculopathy, but in this case, electrodiagnostics confirmed a lumbar plexopathy involving the posterior division of the lumbosacral plexus, preferentially affecting the femoral nerve. So we all draw the brachial plexus, and I think most of us, if you put us on the spot, could reproduce it pretty quickly, and we can rationalize through it in our heads. But the lumbosacral plexus is it's a sneaky beast, and it's hard to remember what's the anterior and the posterior division because there's this rotational element that happens with embryology, and so it seems like I have to dig this out of a textbook on more often than I'd like to try and trace back to figure out where pathology is stemming from. And so in this case, I've kind of highlighted the lateral cutaneous nerve of the thigh, or what we call the lateral antebrachial cutaneous, which if this patient has, diabetes and maybe some peripheral neuropathy and a little neuralgia paresthetica, that clouds the picture further. But there we've got the femoral nerve depicted and the common fibular branch, which wind up being a component of the anterior division of the lumbosacral plexus. So let's talk about lumbosacral radiculoplexus neuropathy, which is the term that they like us to use for what has previously been called neuralgic amyotrophy of the lumbosacral plexus. See, the terminology gets you every time in these things. Can't even decide what we want to call it. So about 8 out of 1,000 diabetics, and about 1 out of every 2,000 to 6,000 vaginal deliveries, and then of course various fractures can result in plexopathy. So pelvic trauma, compression, obstetric complications. In fact, I had a young 30-year-old woman in my clinic who had intrapartum femoral neuropathy and because the adductor was involved, we called it lumbar plexopathy from fetal head compressing the lumbar plexus along the pelvic brim. It got a little bit better after delivery of child number 2, and then just saw her, she's about 6 months out of child number 3, and she developed it on the left side. She has a very short torso, and we think that contributed to this. So bilateral lumbar plexopathy from intrapartum, not delivery complications. And she's got some permanent atrophy, so this is not something that necessarily resolves spontaneously or quickly. So vasculitis, diabetes, and we think pre-diabetes, those with metabolic syndrome, may also be at risk for plexopathy. In fact, sometimes patients with plexopathy present, and then they become diabetic in those 6 months around their presentation as diabetic. And what's funny is we'll often see a 10 to 40 pound weight loss preceding the onset of their plexopathy. So pathology, we think there's probably some sort of vascular component to this, and there's probably an immunologic component as well. So typically they have pretty severe pain at the onset of symptoms, and then it's followed by patchy paresis anywhere between 1 and 3 weeks later. Striking atrophy of the quadriceps is usually what we see, and this manifests more commonly when I get that EMG needle in their leg and I realize that within, probably 3 centimeters, I'm at their femur, I'm at periosteum, and it's quite striking. About 30 to 50% have sensory complaints, and it's typically thigh. Occasionally they get it into that medial foreleg, but typically it's not lower segments. So there's that weight loss. The trick with diagnosis here is that, again, traditional nerve conduction studies, we're going to rule out lumbar radiculopathy and peripheral neuropathy. But unless you do a femoral nerve study, chances are you're going to miss a lumbar plexopathy. And so electrodiagnostic studies can be helpful to distinguish from radiculopathy, but you really have to do those proximal nerve conduction studies to get some meat out of it. So treatments, there is a subset of patients with lumbar plexopathy that have what's called conduction block, which is a manifestation of that we see on nerve conduction studies. And those patients may respond to IVIG. In addition, corticosteroids, not ideal for a diabetic. Normalizing blood sugar and, believe it or not, weight loss has demonstrated benefit. So they have pretty variable outcomes. For some of these, it's self-limited and they're able to get back to life as they know it. But for a lot of these patients, they continue to have thigh weakness, poor endurance, fatigability, and knee buckling, which is always a difficult rehab problem to address. And then last but not least, a good old case of foot drop. So you all know the dermatomal distribution for the lumbar roots. I'm not going to reiterate that. There is a little bit of overlap, and so we go to our textbook, but they're not perfect. And then sclerotomal patterns from the lumbar facet joints are really not well outlined. We have that lovely map of the neck with, the C4-5 is here and the C5-6 is here, and even then it's a bit nebulous, but it's even less discrete when it comes to lumbar facets. So here's kind of one orthopedic perspective from 76 on the direction of sclerotomal radiation from lumbar facets. And then, of course, don't forget your myofascial conditions. It's not uncommon that you have someone with a gluteus medius trigger point that has funny radiating stuff down into their lateral foreleg. That's just a pattern that you see, and when they get the myofascial component treated, their radiating symptoms go away. Obviously, in myofascial conditions, you don't get reflex abnormalities, you don't get weakness. You may have objective sensory loss, but you get normal electrodiagnostic and motor studies. So here we have a 48-year-old obese female with chronic low back pain for 20 years. She has insidious onset of a right foot drop that started 3 weeks ago. She has history of a gastric bypass surgery with a 60-pound weight loss over the last year. And yesterday, because of her foot drop, she tripped over her toe and sprained that ankle. And I bet our therapists are like, oh my gosh, I've seen this patient, but I made it up because I've seen this patient over and over and over again. So on physical exam, soft tissue swelling, tenderness in the ankle, consistent with an ankle sprain. She's got a negative straight leg raise, but she's got pretty weak dorsiflexion and ankle eversion. She's got diminished Achilles reflexes, but normal patellar, and diminished pinprick in the right lateral foreleg and in the dorsum of her right foot and the first web space. So her lumbar MRI looks like lots of other people's lumbar MRI. And so a musculoskeletal ultrasound was done to grade her ankle sprain. She had a grade 3 tear of her anterior talofibular ligament and a grade 2 of the calcaneofibular ligament. So now we have some permanent ligamentous damage thanks to our foot drop. It's just to dust that off for you orthopedists. Remember, ankles. So let's talk about fibular neuropathy. And the first thing I want to mention is that the peroneal nerve died long, long ago. The anatomists changed the name in 2007. So it's time for us all to join the ranks, and we need to call it the fibular nerve, even though we don't want to. So it's the fibular nerve. In fact, they changed the lateral femoral cutaneous is now the lateral cutaneous nerve of the thigh. There are several other cutaneous branches that changed back in 07, 08. So if you're going to publish studies, make sure that you use proper nomenclature. So risk factors. Weight loss and anorexia is a risk factor for fibular neuropathy. Fat is good when it surrounds your nerves. So when you lose fat, you don't lose fat in discrete areas, you lose it everywhere. And it's funny how many patients come in with ulnar neuropathies and fibular neuropathies after sudden weight loss. So obviously leg crossing, as you all uncross your legs. And we've all seen those cases of patients who, they've got a foot drop, they're a young person, their MRI is clean, and you ask them, do you tend to cross knee over knee? Oh, I do that all the time. And then they come back in 6 weeks later and say, after you ask me that, I do that all the time. And I think that's probably our biggest culprit, is that habit. Prolonged squatting is also a risk factor. In fact, there was an article that came out about strawberry pickers palsy, and apparently strawberry pickers engage in constant squatting. And so if you have a strawberry picker or some agricultural workers that are doing a lot of squatting, they may be at risk as well. And then ganglion cysts, which is interesting because we don't think about ganglion cysts around the knee, but there is an interarticular branch, nerve branch, to the joint itself that can then track back joint fluid to the fibular nerve around the fibular head. So THA, TKA, arthroscopy, osteotomy, limb lengthening procedures are all risk factors, and obviously fractures. But from an endocrine standpoint, patients with vasculitis, diabetes, and thyroid disease tend to have more nervy kind of stuff. They often have twice the risk of carpal tunnel, and they're also at higher risk for fibular neuropathy. Obviously childbirth, and we've probably all seen cases like this. I had one where the woman came in with a foot drop on the side that her husband was retracting during the active phase of labor. The nurse was retracting the other side, and it was the husband's retraction that caused the fibular neuropathy. We didn't tell him. So, and then perineoplastic causes. So I think the biggest challenge with foot drop is ruling out L4, L5 radiculopathy, but also true sciatic neuropathy, because I hate the word sciatica because it confuses things. You know, radiculopathy is root. Sciatic neuropathy is sciatic nerve. And typically it affects the fibular division more than the tibial. It's just more persnickety. So traction of the sciatic nerve, compression. The worst case of traction I ever saw was I had an oncology friend who fell in the parking lot and did the splits and came in with a foot drop. He was terrified. He had ALS. But it was a traction injury to the sciatic nerve. Gluteal or posterior thigh compartment syndrome, so-called piriformis or deep gluteal syndrome, penetrating trauma, hip surgery, and then this one here called ischiofemoral impingement, which is depicted on the MRI here. I just saw a case of this about 6 months ago in a fellow who had a really narrowed space across his quadratus femoris. And so this is usually the lesser trochanter against the ischium itself, or the ischial tuberosity. Did I get that right, Daniel? Okay, all right. And so this is a big nasty slide that helps you distinguish differential diagnosis of sciatic neuropathy versus common fibular neuropathy versus L5, S1 radiculopathy, and lumbosacral plexopathy. So it's kind of a nice little thing to put together. It does have some electrodiagnostic findings on there that we use as well. So I'll leave you with this. I finished with 5 minutes to spare. How about that? So there you have it.